So as Helen said, we're talking about community-led approaches to health. I'm just going to start off by just talking a bit about Community Development and Health Network, or CDHN as we're known. Some of you may be aware of us, but for those who aren't aware of what we do, just to give a bit of background to our organisation, our mission is to end health inequalities. All of our work has that focus, and we've been doing this for coming up to 30 years now. We work all across Northern Ireland. We're a regional organisation, but our office is based in Uri. We are a membership organisation. We've over 2,300 individual members from across all sectors, and we have 100 volunteering community organisations as well as members. The unique nature of our membership helps us bring people and communities together and work at community, local and regional levels, bridging the gap in knowledge and understanding to tackle health inequalities. In this seminar, we're going to talk about the importance of trust, relationships, partnerships and networking to successfully involve communities in social change initiatives to tackle health inequalities. Kathy's going to give examples of our two flagship community development programmes, Building a Community Pharmacy and Elevate, and I'm going to talk about the recent research we completed on medication safety and social determinants of health. So I'm just going to pass over to Kathy now just to talk through some of our flagship community development programmes.
Thanks, Helen. So I suppose we're just to introduce the key concepts of health inequalities and community development and kind of set the scene for what we're talking about today. You know, there are so many different definitions of health inequalities, but generally we're talking about the unfair and avoidable differences in health. So those differences that are serious and systematic and are directly related to who you are and where you come from. So by that, we mean the social determinants of health, sometimes described as the conditions in which we are born, grow, live, work, and age. And so addressing health inequalities requires a focus that includes the social issues which affect people's health and communities' health, as well as those more traditional, individually orientated interventions. And that's where the community development approach really comes in most powerfully. So again, there are lots and lots of definitions of community development, not just here in Northern Ireland, but across the world. We tend to use this one, which is a Department of Health definition, and it's from the expansion of community development approaches. And really, I'm not going to read it out, it's there, but really when we're talking about community development, it's just that way of working where people tackle for themselves the things that they have identified as being important. So it's about developing the skills, the knowledge, the experiences of people in local communities and giving them the opportunities to come together to work directly with decision makers and to be involved in all of those processes. So that's kind of summing up our approaches to community development. So Helen, will you just nip on? So this slide really is just an opportunity for us to talk a little about community development from a CDHN perspective. And as Helen said, we've our 30-year anniversary next year. I've been working in CDHN for over 20 years. And I often think about the very first time I went out to a meeting with the director at the time, who was Ruth Sutherland. It was the first time I'd been to, an official meeting with CDHN, and it was community development training. And Ruth used two similar pictures in the training. And what she talked about is that in Northern Ireland, community development practice often looks a bit like a bunch of cut flowers. So we know that this is something that's really vibrant and exciting. Everybody loves to see good community development practice, but actually the way that it's funded with short-term and piecemeal funding means that often that work is lost in the longer term. It's a bit of a snapshot in time. And what her vision for our community development health network and for community development practice in Northern Ireland was to move towards this analogy of a garden. So somewhere where community development practice could be just as beautiful and vibrant, but more planned and sustainable. So you would have those kind of deep roots into communities, and that the community development practice would be developed over a longer period of time. And what we always want, to ensure is that there's always space new ideas to blow in the wind, for pieces of work to happen spontaneously as they're needed. Because community development is about responding to local needs, there needs to be that flexibility. So I like to use that and kind of share that analogy to set the scene for this work. So why community development? Why does it work so well in terms of health? And as I said, it is about that, using the energy and the leadership of people. It's encouraging communities to articulate their own needs and recognising the importance of those social support networks. It encourages partnership working and emphasises collective action. So community development fits well with a population health approach, and we're headed now with the restructuring of our health system. So community development really recognises the root causes of inequalities, and that they are complex, and that they encompass many social issues outside of the medical focus. And often approaches to improving health for the most vulnerable in our society focus more on maybe exchange in information and education and behaviour change, whereas a community development approach will go deeper and use people's own knowledge of those issues in their local communities to tackle them. So just a little bit then of information. I know from some of the names coming up on the screen that many of you will have heard of the BCPP programme before. So Building the Community Pharmacy Partnership Programme is a funding programme that CDHN have been managing for over 20 years. And during that time, we have funded 1,045 individual partnerships right across Northern Ireland, where communities and their local pharmacists have worked together on a project to tackle health inequalities. There's been over 7 million total investment, and across Northern Ireland, there's I believe 262 or 3 pharmacies in Northern Ireland, and to date, 90% of those pharmacies have been involved in the BCPP programme. So it's a well-established programme. So as I said, it's about bringing community and pharmacy together to address health inequalities. And one of the beauties of the BCPP programme is that we have this model. So all of the organisations who are funded through the programme, and every year we distribute 400,000 in small grants across Northern Ireland, and each one of those projects will use the same process for the work that they do, and this is our model of working. So it's very much based around group work. It's about small and intimate group work, because if you think about some of the health issues that are experienced by people in our communities, and especially people maybe who are vulnerable and who have poor health, health is a really personal and emotive subject to talk about. So to be able to engage with your local pharmacist and your community in a small group of about 12 to 15 allows people to build up those connections and to build up trust and develop relationships. So that's a really important part of each of the projects. Co-production is about how each project is led by the group itself. So it's up to the individuals in that group, with the support of their pharmacist and their community leader, to identify what is it that's really important to them, what are the things that they want to look at and to work with, and then using that asset-based community development approach. How do they bring in and include other assets within their community to enhance the work that they're doing? So in each of our projects, there are the community, the pharmacy, and then the other voluntary and community partners. So I suppose just to kind of introduce the model in the context of each of the projects are working in the same way, but yet when you see what they're doing and what the projects are about, they're so different. And the diversity across the programme comes really from the adaptability of this model, that any group, no matter what it is they're focusing on, are able to use these core components to do their project. So it might, what we might have is a group of a community group who are supporting people in a geographical area, or it might be a specific group supporting people who are homeless or at risk of homeless. It could be a group of people with addictions. It could be a breastfeeding group, an older people's group. So really there's a flexibility there that the model can be used by any group in the community who want to work with their pharmacist.
Next slide.
Yeah, sorry, thanks, Helen. I think what I wanted to do really just in these few slides and talking briefly about BCPP, because anybody who knows me knows I could talk about for a very long time and sometimes do, is really to pick out what are the key elements of BCPP that work so well and what are the things that really embody the programme. And this idea of equal and reciprocal relationships is really important. So BCPP programme is really about shifting the power dynamic and addressing that power imbalance that traditionally we find in relationships between people and communities and health professionals. So BCPP aims to break down those barriers. Some people refer to it as removing the white coat, you know, from the pharmacist and seeing them as a person within that community and the assets that they have. And BCPP isn't about the pharmacist coming into the community and being the font of all knowledge, although they undoubtedly bring lots of knowledge to that group. But it's the two-way process that's very important. So the communities have a lot of information and knowledge that sometimes fills the gap for the pharmacist. You know, they bring that local context, and it's that local context that's really important, that tacit knowledge that can help you to understand why some people in local communities find it harder to protect their health, to improve their health, and to look after their health. So it's very much about that two-way process. Thanks, Helen. And I've already mentioned trust, but it's so important. I just wanted to kind of talk a little bit more about it, because any of you that have been involved in partnership working or any type of collaboration will know that it's pretty hard work. Building relationships and trust can take a long time, and you know, it takes a lot of investment. And through the BCPP programme, the pharmacist almost gets to piggyback on some of the existing trust that's already been built up in communities. And sometimes that trust has been built up over years and sometimes over decades. So they're able to come out into the community setting to engage with the group and engage with people in a place where they already feel safe, where they already have connections, and where they already feel that they belong. So that creates that safe space for engagement and building that. And the relationships and the trust that are built up through these projects, you know, bearing in mind that each project is about a year. And now people can come back in again and they build on those projects over time. But the relationships and the trust that's built up there is much more sustainable. You know, we know that it lasts for many, many years, and that it multiplies within communities. So you might have one organisation working with the pharmacist, then the pharmacist might link up with a different organisation in the local area, and you're really starting to see the connections building up locally and the creation of those of that social capital within an area. Thanks, Helen. I've just included this slide because I love it. It's one of my favourite slides. And I think we could probably use this in anybody's work. But often when we're engaging with our new BCPP groups and our pharmacists together, we'll show this slide and tell them to think about who's in the room and think about what it is they're doing. So a pharmacist maybe thinking about the key public health messages that they want to share and they want to engage with communities about, but then using the knowledge of who's in the room, using what they know about them when they get to know them better, what they're interested in. And this shaded bit in the middle, we often talk about, that's where the magic happens. And that's where in community pharmacy, this is where the BCPP programme operates, in that space where people are kind of really finding how this is relevant to their local community. So also, in addition to BCPP, our other flagship programme is the Elevate programme. And CDHN has a long history of community development, health inequalities training. And since 2019, we have been delivering the Elevate programme, a regional capacity building programme, which is commissioned and funded by the Public Health Agency. And there are a number of elements to the Elevate programme. There's a training element, and we deliver community development, health inequalities training, both face-to-face training across Northern Ireland and also online training, just whichever people would prefer. And that training has a great uptake by community and voluntary sector, but also the public sectors. And it's a great way for people to increase their knowledge and understanding of community development and health. There's a portal with lots of information and resources available. There's a mentoring and grants programme as part of Elevate, and that means that community organisations can apply for a small grant of £5,000, and they are then mentored through the use of their grant and on their community development approaches by one of our four or five community mentors. And we also have a reflective practice tool as part of Elevate, which is a really practical tool for communities to assess their own community development practice and identify areas where they'd like to improve their practice over the course of the mentoring. Thanks, Helen. Okay, so to date, there have been 118 projects funded through the Elevate programme and just over £500,000 investment and over 1,000 people trained. So that's since 2019. Okay, now we're actually in the middle of doing, just finalising an impact report for the Elevate project, and this is just a little snapshot of some of the feedback. In CDHN, we're really interested in the why. You know, we want to know what works, who does it work for, why does it work? If it doesn't work, why does it not work? So they're the type of questions that we ask. And when I hand back to Helen, she's going to talk more about the research. But just to say that evaluation and measuring impact is really an integral part of what we do in CDHN. And in both Elevate and also in the BCPP programme, we are very much focused on impact. With the next slide, Helen. And this is some of the feedback from the mentees as well.
Is that, do you hand over to me now?
Yeah, just one last wee bit. So just going to say from the mentoring programme and in BCPP as well, that, you know, we have a robust evaluation framework in BCPP, and we evaluate each of the projects that we fund individually, and then we use that framework. It allows us to aggregate that data up at a regional level and report on that. And Helen is involved in writing up impact reports for both BCPP and Elevate, and we were just saying before today's session, if it was appropriate, we could use this network to disseminate that as well if people were interested. And what we know, just before I hand back to Helen, what we know from our evaluation of both Elevate and BCPP is that they are more than a sum of their parts. We know that funding and training and support, you know, funding is of course a catalyst that allows this activity to happen, but it's really the mentoring, the capacity building and the support element of these programs that leaves the lasting impact in communities. It leaves those communities in a better position to respond to local needs, and the connections and the relationships and the trust that's there is, you know, is there for years and years to come. Okay, thanks, Helen.
Thanks, Kathy. Sorry for skipping ahead there on a slide. Yes, and as Kathy said, I'm actually in the process of finalising the Elevate impact report, and the BCPP one should be ready at the end of December as well. So we'll be happy to share them with you whenever they're finalised as well. So I'm going to talk a bit about the research that we recently completed in CDHN. It was launched in June of this year. It was called Our Lives, Our Meds, Our Health. And the research aim was to discover the social circumstances behind unsafe medication practices and avoidable medication-related harm to inform the implementation of the Transforming Medication Safety Plan in Northern Ireland using a community-based participatory research approach. So essentially the aim of the research was to find out how things going on in people's home or in their lives impact their ability to take the medication. So why do we do this research in the first place? Well, it really came out of a challenge by the World Health Organization in Medication Without Harm to reduce medication-related harm by 50%. The Northern Ireland Department of Health took them up on that challenge and wrote a medication safety plan for Northern Ireland. We have a good working relationship with the Department of Health, and they approached us and asked us how to get communities involved in the medication safety plan. We had a really good read of the medication safety plan, and what we realised was that health inequalities weren't really included in it. And also what we noticed was that it was very much from a health and social care perspective, and the social determinants and social factors that influence health weren't really obvious in the plan. And we went back to the Department of Health and said, would you be interested in funding a scoping study to find out more about the social factors that impact medication safety? And they said yes, and this is where the research essentially came from. So research shows that socioeconomic factors have more an impact on health than physical environment, health behaviours and health care. And as I said, with that in mind, the research explored the social factors that impact on medication safety. The things going on in people's lives are things personal to them that might cause them to take the medication the wrong way. So we know that health follows a social gradient, and those experiencing inequality are at a higher risk of health. In Northern Ireland, preventable mortality is 3 times higher in the most deprived areas than the least deprived areas. But really, one of the statistics that really made us interested in this research was that 50% more prescription items are prescribed in the most deprived areas in Northern Ireland compared to the least deprived areas. So just to talk about what a community-based participatory research approach is. So it's a partnership approach that equitably involves key stakeholders in the research process. It begins with a topic of importance to the community and is the aim of combining knowledge with action and achieving social change. So just to talk through what the difference between traditional research and a CBPR approach is, and so just so you can understand why we use this approach in our research. So when you have traditional research, the issues are identified are based on the research data and the funding priorities, whereas in a CBPR approach, the community identified the issues of importance. And we actually we explored whether that was an issue in the communities, and I'll explain that in the next slide of the approach that we used. In traditional research, people are the research subjects, whereas in CBPR, people are participants and collaborators in the research process. So people are involved throughout the research process, not just in the focus groups or in any of the not just as research participants. In traditional research, only researchers gain the knowledge and skills, whereas in a CBPR approach, all stakeholders gain knowledge and skills. In traditional research, the study design is developed by researchers, whereas the community are involved with the study design and CBPR approach. In the traditional research, the recruitment process is developed by researchers, whereas in CBPR approach, the community give guidance and support to recruitment. And then in traditional research, the findings are printed in academic style and peer-reviewed journals. But in a CBPR approach, community members help with interpretation and dissemination of findings, as well as having that academic style and peer-reviewed journals. But we also are very considerate of how we can get that information out to the community members as well. So really, I'm going to go over the approach that we used in this research. The first stage was our desk research, and then the second stage was our stakeholder engagement, and there's 3 levels to that. The first stage was a voluntary community organisation survey. So we put out a survey to all of our members and asked them, was medication safety an issue in their community? And if they thought it was a health inequalities issue. And thankfully it came back that people did recognise it was an issue in their communities. And then that made us, well, it's not thankfully that it was an issue, thankfully for our research process, we knew then that we were researching what needed to be researched. And also what we did that survey was ask people, did they want to get involved in the research process? And I think we had about 100 people come back and said they would like to get involved in different elements of the research as it continued. We then had stakeholder interviews. We interviewed 6 people in the voluntary community sector and 6 people in health and social care. And the purpose of those interviews was really to find out what should our research questions be, what should we be asking in this research, and who should we who should our sample be, who should we be speaking to. We took that and wrote a stakeholder emerging issues report and went back to our steering group and then took their advice on who our research questions and our sample. And then the next stage was our actual research, which was awareness raising and data collection focus groups. And we had 8 community focus groups and 4 health and social care focus groups, which I'm going to explain a bit more in the next slide. Then we had an interim refinements report where we wrote up everything that we found in the focus groups. The next stage was our stakeholder engagement again, where we held a knowledge exchange workshop in Belfast, and we invited everyone who's involved in the research up to that point to come along to this workshop. We put up the findings all across the wall, and we asked people to say what did they think was most interesting, what should we do next, what should the recommendations be, is there anything that stood out for them, so we could really get them to input into our final report. We wrote the final draft report at that stage, and then sent that back out to everyone involved again before we wrote our final report. So that was the process that we used to ensure that people were involved the whole way throughout. So in terms of the community sample, this was really where our trust and relationships came in. I spoke about this research at the European Public Health Conference last week, and what people were really interested in was how did we get 8 focus groups and 63 people to take part in this research. And the reason we were able to do that was because of the trusted relationships we have in the community. When we identified the areas where we wanted to target people, we contacted organisations in those areas and said, would you be interested in hosting a workshop for us and bringing people along to it? And it was because we had those connections in those local communities, they were more than willing to host a workshop for us and get people to come along to our workshops. Interestingly as well, when we were about 6-7 workshops in, we realised we hadn't enough men. And we had contacted 2 men's sheds who had nothing to do with the research up until that point, and they were more than willing to help us out and host a workshop for us. As it turned out, we only needed 1, but it was that trust and relationships that we have with communities across Northern Ireland that enabled us to do this research. And then with health and social care, we had to get ethical approval from health and social care to speak to people who are employed by health and social care in this research, and we were delighted to get that ethical approval. But also it was really our trust and relationships with health and social care that enabled us to do this as well, because we promoted that research really ourselves through everyone that we have, our members and the connections that we have throughout health and social care, and we got those participants to take part in that research too. In terms of the findings, there is a full copy of the report available to download off our website. We can put it in the chat for you as well. I'm going to talk through some of the key findings. I'm conscious of time, so I don't want to go through them all in an awful lot of detail, but I will give you an overview of them now. We had 6 key themes, which I'm going to talk through. The first key theme, as you would expect, was the social determinants of health, which was the focus of the research. And what we found was that people intentionally and unintentionally don't take the medication as prescribed. So some of the intentional things were like, if you can see there in the bottom left-hand corner, somebody said, I purposely don't take amitriptyline on the nights to stay up with my granny's because I know it makes me tired and I have to be able to stay awake because I have to be able to hear her if she gets out of bed. So she didn't take a medication because she was caring for somebody else. But then other people were saying, if you're out of routine, you just forget to take your medication, as you can see there in the top right. If you're anywhere else but at home, I don't take them because I forget. And then we found out as well, there's a lot of information sharing, or medication sharing actually. People shared medication, often for altruistic purposes, just to help people out. Like when my husband died, of course my kids gave me this wee tablet that night and I didn't know what I was taking, but somebody was doing them to help them out sharing the medication. And a lot of people didn't realise the implications of sharing medicine and how actually it could be damaging, and didn't realise that really it was a medication safety issue. And then you've other people, because of, maybe it's a disability, or it could be opening medication, managing medication, lots of other reasons why people don't take the medication. As that person says at the bottom, I actually said to my husband yesterday, when are you to get reviewed? They told me just to phone. Well, he's autistic and he's never going to phone. So there's so many social factors that impact upon people's ability to take the medication as prescribed. The second theme is health literacy. Health literacy is is recognised as a social determinant of health, and we thought it would come up in the research, but it actually came up as such a dominant throughout the research. We felt it warranted its own theme, and we really felt we had to put it as its own chapter in the research. And what we found was people had varying abilities accessing, receiving, and understanding instructions, advice, and guidance for the medication. And it was really influenced by many sources, including family, friends, community networks, research, and wider media. So people weren't sure what medication they should be on. Like if you can see there on the top, half the medication I'm on, I don't even know if I should be on it. I've been on medications that long. Other people didn't know how to take it correctly. So again, somebody said, for years I've been taking levothyroxine. Only recently I found out I should have been taking it half an hour before eating. And since in a week I've taken it, I feel like a new person. So somebody didn't even know how to take the medication correctly. And then you've other people who are really influenced by what was going on in the community. People said, I just hear a lot of people, I was listening to other people saying, oh, I can't take them, they're no good, they're damaging. A lot of people were talking about, particularly with preventive medications such as statins, people just didn't really understand why they were taking them, and they were listening to what other people said rather than maybe the health professional about why they should take their medication. In terms of reporting errors and concerns with medication, some people have really positive experiences of healthcare professionals listening to concerns in changing the medication, and others really had experience of the healthcare professionals not listening, or patients feeling judged or criticised when they reported an issue. But also people were embarrassed to say that they didn't take the medication as they should. As somebody said, you wouldn't even want to go and admit that you aren't even capable of taking 2 tablets. You wouldn't want an ass out of yourself. You'd rather suffer. And then people were concerned that if they reported they took the medication wrong, they might get into trouble. So there in the bottom, somebody said, maybe we would be too worried to admit that you screwed up. You might think something is going to happen to you, so you just keep it a secret. There was a wariness of maybe social services getting involved or something would happen to them as a result. In terms of making decisions about medication, most people, generally everyone we spoke to, would like to be given the opportunity to be more involved in making decisions with the medications. Positive experiences where people working with healthcare professions to change the medication being fully explained and being given the opportunity to make the decisions. Whereas the negative experience where people feeling that their opinions were not listened to, medication being prescribed that would not address their issue, or being told they must take a medication. And what we found was a lot of people really interested in having alternatives to medication, or maybe reducing their medication intake, or looking at other ways that they aren't taking medication all the time. And people are really keen for that to happen. In terms of health and social care, it was another theme. We didn't directly ask people about health and social care systems, but inevitably it did come up all the time. But some of the things that people spoke about was that a style of working in health and social care can create confusion for people in the community. And there sometimes can be a disjointed approach to applying policies and procedures for medication, both across and within the health and social care trust areas, for example, in the administration of blister packs. So I think probably within health and social care systems, there is some system issues that people in just general people in the public are aware of, because it impacts their medication. And I know it wouldn't be remiss to say that people keep on talking about the shortages of GP shortages and doctor shortages, but people were at the same time very appreciative of the health and social care system and what it offered, and understand that there are shortages out there. For those of you, I don't know if many people know about No Check Ask, but No Check Ask was a campaign that was launched by the Department of Health. It was about a year ago now. There is a promotional campaign with a leaflet where it's up there on the screen, where people can fill in all the medication, so they can see what it is they're taking, when they're taking it, how they're meant to take it. And there's a campaign to say No Check Ask, both for the pharmacy, or not for the health and social care staff, and also for people in the community to No Check Ask. The Department of Health asked us to explore this campaign and people's thoughts on it as part of the research. And what we found is that people were quite welcome of the campaign, but they were afraid that it would fall completely on community and voluntary organisation, or community people to complete it, and the onus would be on the individual to complete it rather than health and social care. And then there's just a lot of people brought up the practicalities of updating the form after changes. And then health and social care brought up the issues around time constraints and staff shortages, can mean it's more difficult for health and social care professionals to practice No Check Ask. So just some key learning and conclusion, just an overview of everything that we learned. We find out that medication safety is a health inequalities issue. It's often overlooked in policy and practice. We find that everyday lives and social circumstances can impact people's ability to take their medication as prescribed. There are varying abilities in accessing, understanding, and using information about medication, and sometimes health and social care don't recognise this. But it's also influenced by many sources, including family, friends, community, media, social media. People would like more options for alternatives to medication. Some people have difficulty accessing medication reviews. People are unsure how and what to report about medication. No check ask is welcome, but more support is needed. And what was also clear is that local needs, social practices and norms need to be considered in any programmes or initiatives around medication safety. In terms of report recommendations, we had 14 recommendations for the implementation of the plan and 7 for beyond the plan. If you have a copy of the report, we go into a lot of detail on those recommendations, and there's a lot of action points under them. I'm just highlighting some that are of really interest to CDHN, but for other people, there may be other ones that are of more of interest to them. So I do urge you to go and look at the report and see if there's anything that stands out for you. But the key things for us were taking into account the social determinants of health and health literacy in the future implementation of the plan, co-producing a community health literacy programme focused on medication safety, developing a communication awareness, promotion and engagement strategy for the plan, and reviewing training and learning for medication safety for all those who work in health and social care. And then I've put this one down here, to reconvene the Health and Social Care Regional Health Literacy Forum, because that's actually happened since the report has been written. I can't take credit for that's the reason why it was reconvened. It was already, the talks were already underway, but I do know that it was one of those things that people are saying, yes, this is an issue we need to address. And that's me finished as well. There's just our contact details if you'd like to find out more information.